Good to see you. Happy Tuesday afternoon. I think it's officially afternoon for you folks on the Pacific Coast. Give you all a minute to get connected. It's very good to see all of your faces. Some of them I saw yesterday, so welcome back again today. You guys are just really good at tuning in and staying connected, and I love seeing that. We're going to be doing an interactive program today. This is a program in partnership with Amneal, and we're going to be talking about the different formulations of Carbidopa, Levodopa. Some of you may have attended a program that we did earlier this year with Dr. Hauser, and he talked about immediate release, controlled release, and extended release. And we have actually taken some of that video and we have clipped it down, and we're going to show you little excerpts from it today. And then we have Sherrie Gould with us, and I'll do her intro in a minute, but she's going to be talking us through that. We have some additional information we want to offer, but we also want to give you an opportunity to ask questions about it. I know it can get really confusing. We throw these terms around. What's really the difference between extended release and controlled release? And how does this really work? And when should I be using these things? So we're going to try to help demystify this a little bit for you today. So I want to go ahead and introduce her, but first, please open up your chat box, because that's where you're going to ask your questions. We're going to try to answer them as we go along. And yes, please give us a shout out and let us know where you're joining us from. I love seeing where folks are tuning in from. And I want to also just give you a heads up, because we're having some internet issues with some of our team today. I'm going to be facilitating and sharing the video. And so you have to be patient with me, because tech is not my strong suit. That's not my forte. So I'm going to do my best to share the screen, show the clip, and then come back to you and look at your chat and answer these questions with Sherrie. So I'm asking for a little grace today, just in advance, just in case. So I'm very excited to have this conversation, because I think this is something a lot of people are really interested in. So with us today is Sherrie Gould, and you probably recognize Sherrie. She's been on so many of our programs. She's one of our favorite partners to work with, who's an advanced practice provider. She's a board certified nurse practitioner. She's at Scripps Clinical Movement Disorder Center in La Jolla, California, and she has a master's of science in nursing from the University of San Diego, a bachelor's of science of nursing from University of Michigan. And she is a national speaker on Parkinson's and has been a very involved speaker for us at PMD Alliance. So Sherrie, thanks for joining us.
Wow, thank you. Thank you so much for that nice introduction. I'm excited to kind of, like you said, demystify some of these huge questions about Carbidopa, Levodopa, the gold standard. So why don't we just go ahead and roll the part of the video, and we can get right into this and kind of really talk about all these different forms of the gold standard Carbidopa, Levodopa.
Awesome. Okay, so I'm going to do that. So bear with me a second. I'm getting ready to share my screen. Here we go.
In early Parkinson's disease, levodopa gets up to the brain, gets into remaining dopamine neurons, is converted to dopamine, and then is slowly released to where it needs to go. And that there's that good storage and release component that makes it last many, many hours. In fact, you might be able to take it once a day, and it could last all day long early on. But as time goes by and people lose more of those dopamine neurons, the ability to convert levodopa to dopamine, store it, and slowly release it over many hours diminishes. For immediate release, it depends where you are in your Parkinson's disease. I said for IR, initially it can last many, many hours, but as time goes on, your response begins to shorten until you're going up and down, just like the levodopa in the blood. So for IR, patients' response shortens down to 4 hours, 3 hours, 2.5 hours, until they're going up and down with their IR. Treatment we didn't talk about are the so-called on-demand therapies. On-demand means you take them as needed. So rather than having it every day all at the same time, you can take it, let's say at 2 o'clock on Thursday. If you're off, maybe unexpectedly, you can apply that medication. There's one that's inhaled levodopa, and there's one that's apomorphine under the tongue, and there's also an apomorphine injection. All of those are effective. They all have subtleties to them, but the key is they're as needed. They're not part of your regular maintenance schedule.
All right.
All right, that wasn't too bad.
That was perfect, actually. That worked really well. It was nice and smooth, no glitches at all.
Awesome.
So yeah, the IR, so immediate release, carbidopa, levodopa, 25/100. The carbidopa portion of that is kind of what we call the anti-nausea. So you will never find just plain levodopa. It just isn't made, because you would be deathly ill if you try to just take levodopa. So really important that we have that. We have actually two formulations. One's at 10/100 and 10 milligrams of carbidopa and 100 of levodopa. And then we have the more common one, which is 25/100. So a little bit more of that anti-nausea effect. And just to expand a little bit on what Dr. Hauser was talking about, is that initially we call it the honeymoon period. And really, when you start taking carbidopa, levodopa, it does get into the brain. And there's an ability of the neurons, of the dopamine neurons, to buffer. It's a term we call buffering. In other words, they're like storage units. They process, they make the levodopa into dopamine in the dopamine neuron, and then they store it. So as you need it, it releases the dopamine nice and slowly. Typically, even though it can last quite a while, I truly have not ever seen it last more than 4 or 5 hours, which is why all of you probably started levodopa taking 1 tablet 3 times a day, and that is a titrated amount. So we start having you take a half with meals, and then every 3 days, at least at our clinic, that's what we do. And it really takes a 2-week period to get up to a full dose of carbidopa, levodopa, and we do that to avoid side effects. And the main side effect, again, even with the carbidopa, can be nausea. We have some other side effects, fatigue. Sometimes people's blood pressure can lower. And then, of course, there's always a potential for some allergy to carbidopa, levodopa, though that is actually very, very rare. Over time, the carbidopa, levodopa still works. One of the questions I hear more than ever from my patients is, why has my carbidopa levo stopped working? Or why is it unpredictable the way I take it and the way it works? Sometimes I'll take it and it works perfectly and I can move and I feel good. And other times it's just like I haven't taken it at all. And sometimes I'll even double my dose and I don't feel any benefit from it. And so as time goes on with Parkinson's disease, there's a couple factors that happen. One, you've lost more of those dopamine producing neurons. So there's less little factories to turn that levodopa into dopamine. And the neurons get a little bit tired, and so they're not as efficient in their production. The other huge factor, and probably even a bigger factor, is the fact that there's a whole issue going on with your gut, a huge brain-gut connection. The gut slows down, just like everything kind of slows down in Parkinson's, and more so as time goes on. And so oftentimes you can take your dose of carbidopa, levodopa, and it literally will just sit in your stomach for even a couple hours. We call that gastroparesis. It's basically slowed emptying of stomach contents. It's why a lot of times people don't get as hungry as time goes on, because you can eat, but it can just sit in your stomach instead of going into the small intestine. The other really important thing for people to understand is the molecule of carbidopa, levodopa does not get absorbed through the stomach wall. It gets absorbed through a part of the small intestine called the jejunum. So one has to get it past the stomach into the jejunum so it can be absorbed and then taken by the peripheral blood system up to the brain, where then, of course, it crosses the blood-brain barrier. So that is actually one of the reasons why, and we're going to talk about this in a little more in more detail, and that is a type of carbidopa levodopa actually called Duopa. And the reason Duopa works is that there's a medicine port and a pump, and the medicine port, it goes into the abdominal wall, and there is a little tube that actually feeds right to the jejunum that we just talked about, and it drips at a consistent, continuous rate for 16 hours a day. It bypasses the stomach, and that's why the concept of Duopa is helpful, because it doesn't have to be dependent on the intestines being able to function and not have that thing we talked about, which is gastroparesis.
Okay, so I have a couple questions for you, Sherrie. So first of all, if levodopa works so well in the early stages of the disease, why bother taking it at all? I know that that's been a question for many people. And to add on to that, could you not start with something else like a dopamine agonist instead of?
So this is very dependent patient to patient. And if there's one thing that everyone hears repeated, is that no two people with Parkinson's are the same, and their needs differ. So if we have a patient, for example, still working, raising children, whatever the case may be, and needs to be on top of their game, the number one most effective medication that we have, even though it was FDA approved 70 years ago, is carbidopa levodopa. So our patients that are in that position, we will start them no matter what their age on carbidopa levodopa, because we need to get the maximum benefit, clinical benefit from our arsenal of medications. We may have another patient who comes in with very mild symptoms, as having maybe a little tremor, a little resting tremor in one of their upper extremities, not really affected by a lot of slowness or stiffness. Then we may very well start them on an MAOB inhibitor, something like rasagiline or selegiline, or the newer one is called Xadago, because they may not need that robust clinical improvement. But for patients that do need it, whose lives and quality of their lives have been affected by their Parkinson's disease, then we are not afraid to use carbidopa levodopa. And I do know that there's a pervasive theory out there, or whatever, which patients come to me all the time and ask me, is that I've heard that once I take carbidopa levodopa, it will only work for me for 5 years, 5. And that is just completely not true. Carbidopa levodopa will work for you from the time you take it till the day that you are no longer on the planet. It never stops working. It's just that that therapeutic window of how long it works and how long it lasts and how many pills you need to take, that therapeutic window for everyone lessens, gets smaller over time. Dopamine agonists are another really good choice. We have 3 of those. We have pramipexole or Mirapex, ropinirole, Requip, and we have a patch. The patch is called Nupro. And that one works really well by itself. And sometimes we do choose to use an agonist before we use an MAOB inhibitor and before we use levodopa. Sometimes we use it as what we call adjunctive therapy. They've already started carbidopa levodopa, and then we can add these other medications. They all work to increase levels of dopamine stimulation in the brain. And they do that differently. I mean, some work by actually putting dopamine there. That's the levodopa. Some work by, they basically just, they stimulate the dopamine receptors, and those are called dopamine agonists. They kind of fake the brain into believing it's dopamine, but it's not dopamine. And then the MAOB inhibitors are really a type of medicine that block an enzyme that breaks down your dopamine in your brain. So that also helps raise dopamine levels in your brain. And I just want to remind those of you who may not have heard this, at the time of diagnosis, we know for a fact that you have lost 50 to 60% of your dopaminergic neurons just at diagnosis. So the brain's ability to compensate for years before you actually go, something is definitely wrong, or your internist or somebody notices something's going on that's not normal, and you end up going to your movement disorder doctor and finding out what it is, and it ends up being Parkinson's. It is really because you have lost over 50% of your natural dopamine producing neurons.
So Sherrie, in the clip, Dr. Hauser mentioned Ambrisia, the inhaled form of levodopa. So is it possible, and why not early on take an on-demand formulation like that? Is that a possibility?
Right. So no, it's really not a possibility. These type of drugs like Mobi, which is this sublingual, kind of like a little film that you put under your tongue. Ambrisia is an inhaled type of carbidopa levodopa. And of course, there's an injectable, we call it apomorphine or Apoquin. And these are all indicated for people that are already taking carbidopa levodopa, and they're intended for off episodes. And what is an off episode? Is that time when your medicine just isn't working. And it, sometimes is predictable and sometimes it is not predictable. You can have both predictable offs and unpredictable offs. But when you have an off period, then those on-demand therapies are wonderful because they will just give you that boost of extra dopamine. You continue to take your regimen of carbidopa levodopa at the same time, but that medicine is there as a rescue, as a kind of a little emergency in case you need it. And obviously is something that you can take out in public. Some of my patients use those type of on-demand therapies before they go to their rock steady boxing class. They just need that extra little boost. And that works. Sometimes we actually even use a little half of a regular IR carbidopa levodopa. And I tell my patients to just chew it. It tastes like chalk. And that gives them a little boost that is absorbed quite rapidly because we've increased the surface area of the medicine and is able to get through the stomach and get to the jejunum where it gets absorbed.
Okay. So I had a question that came in earlier. This person says, when a dosage is changed for carbidopa levodopa, does the 2-week period for full effect of new dosage apply, or 2-week period for full effect only when first starting? So you know how when you take a medication, you need to give it at least a couple of weeks for it to reach its full effect. That's what they're asking. Is that the case with this? And if you increase it, so you've gone to your healthcare provider and they're like, okay, I think it's time to increase your medications now, what's the wait period for that? Is there a wait period?
So there tends to be, people know that there are good days and there are bad days in Parkinson's. People have tougher days for no apparent reason that they can really identify. And then they have good days. So I always will explain, let's take a look, a 7 to 10 day period and see how you feel. Step back, take the good days with the bad days, and overall be able to judge on how you feel. If indeed you, after 10 days or even 2 weeks, truly don't feel any different on an increased dose of levodopa, then we don't necessarily need to stay on that higher dose. I don't want any of my patients on any medicine that's not actually helping them, making them feel better and improving the quality of their life. And sometimes we just need to experiment. Not every drug is right for everyone. And we're just super lucky here in 2021 that we kind of have an arsenal, right? We've got a lot of things to choose from. Goes way beyond levodopa now. We have things that regulate other neurotransmitters in our brain that are affected by Parkinson's disease. So what may work beautifully for one patient doesn't work for the next, and onward and onward. So we need to, I tell my patients to be patient. We're going to work together as a team. We're going to find the right combination that works for you in terms of your lifestyle and in terms of your symptoms, to just maximize the quality of your life.
All right, I have a couple questions that I think are related to the window that you described. So I know we've heard that description, metaphor, whatever, explaining the course of the disease and how effective the medications are. So I'm going to try to put these together to see if you can explain the window a little bit, in doing that, answer the questions. So one of them was early on, if you don't feel the need to take levodopa, and you only take it just one a day or not at all, is that an issue? And then is there a criteria for taking certain amounts of getting to a certain amount of carbidopa levodopa before you would add any additional meds? So now we're wearing off more often, that window might be closing, and at what point do we typically consider it's time to either increase or add an additional medication that you mentioned earlier?
Sure, that's a great question. So one of the main questions I ask patients at every single clinic visit is, can you tell when you need the next dose? Is exercise getting harder? Is it getting tougher to go as long as you were going before? Are you feeling more Parkinsonian between your doses? And if the answer to any of that is yes, then it's time to really take a look at one of our many, many options. And one of many, many options is to make the doses of carbidopa levodopa a little bit closer together. Or one of my favorites, and another thing we're going to talk about after another segment, I'll get into it much more, that Dr. Hauser really introduces, is the extended release carbidopa levodopa called Rythari. That's a beautiful way to basically kind of help with off time without really having to increase the actual milligrams of the amount of dopamine, actually levodopa, getting to your brain. So again, each of you have your own story. Each of you have your own need. Each of you have lifestyle goals. And our job as your clinicians are to listen carefully to what your needs are. And then based on that, decide, do we give you the new pro patch, that lasts sometimes, all 24 hours? Do we change you to Rythari? Do we give you Ongentys, which is yet another one time a day type of medication that again increases amount of dopamine that gets to your brain. So there really isn't just one answer, but I think the bottom line is when you're starting to feel slower, stiffer, more tremorous, and off between your doses, it's definitely time to talk to your provider about making a medication adjustment.
Fantastic. Okay, why don't we move to the next section, which I think it's pretty brief. It's about the controlled release. And there is, I think I mentioned earlier, sometimes some confusion between the difference of controlled release, immediate release. So let me try to share my screen again. Oh, wait. I'm going to have to unspotlight you, it looks like. Let me see. Sorry, guys. Technology is not my strong suit. All right, you seeing it okay?
Mm-hmm.
All right, here we go.
Controlled release is another formulation of carbidopa levodopa, and it's slightly different from immediate release. It's delayed in its absorption by about 15 minutes. It doesn't go quite as high. It goes about 2/3 as high, and it lasts about 15 minutes longer. So it's not very different from immediate release, and it's slower in its absorption. So you kind of lose 15 minutes on the front end and gain 15 minutes on the back end. So movement disorder doctors don't typically use that to try and smooth patients out. By tradition, a lot of docs give it at bedtime because it's very simple and easy, but you're really only gaining 15 minutes even then. So it's not a very good drug for fluctuations. And in fact, it's not really indicated for that in its FDA label.
Okay.
Yeah, it is interesting. As a matter of fact, Merck, who is one of the pharmaceutical companies that makes Cinnamon CR, has stopped production of Cinnamon CR. So if any of you are on Cinnamon CR, I think they're just waiting until their supplies are depleted. So it is true. It doesn't give you, certainly it's not indicated for off. And it is a medication that unless the pill itself, if you are on Cinnamon CR, only if it's scored can you split that. If it's not scored, then if you split it or crush it, it becomes immediate release. So because it's really in the coding. So remember, only the ones that are scored if you ever need to split them. Again, it has been certainly taken over, or the Rythari, which is an extended release formulation of carbidopa levodopa, has become pretty wildly popular and effective for treating off and having that consistent release. So when we think about carbidopa levodopa, we want to think about consistent, right? We don't want those fluctuations. We don't want to have you take a pill and boom, you feel better in half hour, 45 minutes, and then it goes back down just as fast as it started working, which means that it has a short half-life. What the brain likes is what the brain was used to having, which is a nice, smooth amount of dopamine in the brain. So Cinnamon CR, I agree with Dr. Hauser, oftentimes, if we're going to use it, because it is very affordable, it's been around for at least 50 years, is something that we would prescribe at bedtime, not typically during the day.
But now that we have other options, are you even prescribing CR anymore?
No, I don't ever prescribe CR. Sometimes patients come to me with Cinnamon. I mean, they come to us from another practice and they're on Cinnamon CR. So again, it's a partnership. It's like, how do you feel on this? But even in those situations, to be completely honest, I will give patients samples for 1 month of Rythari. Let's just try it. If you don't like it, you can go back to what you were taking. I'm totally fine with that. But my experience anecdotally, not only just in clinic, but also looking at clinical trials of Rythari, it is by far superior. And certainly that must be playing into the whole thing that Merck is actually not going to even, I think they've stopped production already. And so I think Cinnamon CR will soon become a thing of the past.
Okay. Well, I think this is a perfect segue for the next section, which is the extended release, since you are referencing Rythari. So I will go ahead and show that clip, and then we can get into that because we're already getting some questions about that.
A lot of medications are mislabeled extended release. True extended release is Rythari. Rythari goes up as rapidly as immediate release, but it stays up for 4 to 6 hours. So that's significantly longer than immediate release. So Rythari has little beads of carbidopa levodopa in a capsule, and some of those are similar to immediate release. So they go up pretty quick and move on pretty quick. But there are two other kinds. One is kind of an intermediate kind as far as how long it lasts, and one is a longer acting kind. It gets absorbed in a delayed fashion, and so it lasts longer. And when you look at what that looks like it gets absorbed as quickly as immediate release and lasts in the blood 4 to 6 hours before being metabolized and cleared out of blood. So if your medication just has extended release on it, you have to ask the question, am I getting Rythari Or am I getting something that's really controlled release that is mislabeled as extended release?
Yeah, I want to be in that space capsule. Boy, it's a really boring background in comparison.
Well, and I really wanted to reference that because we're talking about capsules and he's in.
That's so funny. Oh my goodness. Yes. So Rythari is really quite ingenious. The kind of the pharmacokinetics of Rythari, because as Dr. Hauser just explained, there are these little beads, and you can actually physically see the beads if you look at the capsule. And so instead of having, which IR has, as time goes on, like a 90-minute half-life, we look at Rythari and we're talking about, 4-hour, 5-hour, sometimes half-life. One still needs to dose it 3 times a day, but you can imagine that instead of having, immediate release IR, that it gets absorbed, it reaches its half-life, it comes back down. So this is what's happening in your brain all day long versus Rythari, or extended release carbidopa levodopa, has those little beads, and they go up and then they stay nice and consistent in your blood plasma and consequently in your brain. So basically think of it as it bathes your brain in levodopa instead of more of the pulsatile. It's there, it's not, it's there, it's not. And that, again, we go back to what we're trying to do is simulate how can we get as close as we can get to what the brain was created to do, and that is to be bathing in dopamine, right? So that when we're moving, when we're exercising, there's more dopamine released, and when we're sleeping, there's less dopamine released. So it is really quite ingenious. Even a little bit further, I find it fascinating is that these little beads of carbidopa levodopa are also absorbed at different pH levels in the gut. So the further south you go in your intestine, the pH changes. So that's part of that slow absorption. The other thing that I think is really important to let people know, and I always point this out to everyone, because it's so slowly absorbed, 50% of the milligram dose that you see on the bottle gets discarded in your urine. So an equivalent dose of IR, Cinemet IR 25/100 is actually 195 because we know 50% gets to the brain, 50% gets discarded. The highest dose of Rythari is 245. But you can do the math, that's equivalent to 125 approximately of Cinemet IR. And again, is quite ingenious the way they've designed this medication, that it is slowly released and gets in the brain at kind of a same level for a number of hours, which is a wonderful advantage for our patients.
So can you take Rythari early in the disease, or do you need to wait when you're experiencing more off?
You can definitely take Rythari early, like start with Rythari. The problem is financial, to be honest. I mean, at least in San Diego, I can't speak for the rest of the country, but if an insurance company, and this is just reality, we need to talk about that too, right? If you prescribe Rythari right off the bat, you want to get someone started on carbidopa levodopa, probably bet is the insurance company is not going to pay for it. It is more expensive than generic carbidopa levodopa, as most of you know, is probably $10 a month to just have the regular yellow Cinemet 25/100. Rythari is definitely coming down in price. More and more insurances are certainly covering it. However, they tend to cover it once they can clearly see that the patient has been on the cheaper form of carbidopa levodopa and that they truly do better on the Rythari. And then the chances that that tier amount of money is going to change is really much greater. So in answer to your question, I would love to start all my patients on Rythari, but logically I can't. Financially, it doesn't work yet with the insurance companies.
And I'm glad that you brought that up because we had a question earlier about needing prior authorization for many of the drug plans because it's not on their formulary. And any suggestions on people, because I know you have to do that step therapy progression sometimes to prove that, you know, really this is more beneficial for somebody versus just taking many meds a day of the immediate release. So is there something you can suggest in terms of like?
So the company itself that makes Rythari, it's called, the name of the company is Amneal, but they have a program called My Rythari. I use it a lot. I have it pre-populated. I just fax it in, and then I let them do all the homework of working with my patients' insurance companies to make it more affordable. They also have kind of grant programs that they can dip into. Very rare that one of our patients cannot afford Rythari, because it's between the My Rythari or more and more insurances paying for it. I would have to say 90% of the patients that I prescribe Rythari for are covered for Rythari. It's not free, and it's probably more expensive than IR, but it's affordable. So yes, there are things you can do.
And just in case people are not aware, Kelly did drop on our in the chat our link in our website that has all the medications listed that are FDA approved and the assistance programs. So you can link right over to Amneal's page and get to their assistance programs and any of the others that might be available to assist you with copays. So another question in regards to Rythari is, if someone's been on immediate release for a while and then they're switching to Rythari, is there any difficulty in switching? Because I know it is a totally different dosing schedule, which you kind of mentioned.
No. So actually, if a patient has been on regular IR, I show them the bottle. I literally want them to see this is just Carbidopa, Levodopa. It's the exact same drug you've been taking. There's nothing added. It's only extended release. So sometimes I can give them fewer doses a day. Say they were in IR every 3 hours. And I can give them I look at the dose of every 3 hours, 100, say they're on 500 milligrams of IR, of regular Sinemet. I double that. I'm like, okay, well, that's 1,000 milligrams of Rythari. And maybe I can divide it by 4, like 245. So I can at least bring it down. So now they're only taking it 4 times a day instead of the 5 times a day. So sometimes we can do that. And then of course, always important that you're communicating with your clinician a month later. So did that work for you? Are you experiencing any off? Do we need to shorten those doses, or can we make it even further apart? But I typically will just stop IR, the Sinemet. I always start in the morning, don't start it this afternoon. Let's take a very fresh day and just start your Rythari. So there is no transition period or titration.
And I'm just curious, are there any different or additional side effects with Rythari that you don't see in extended release? Someone did ask about that in terms of like dizziness and stuff like that.
So that's a really interesting thing to bring up. It's kind of the opposite of that. I had a patient, and this happens all the time. I saw a patient yesterday who's like, you know, I take my Sinemet 25/100, I take it 3 times a day. I take it before meals, which is something we need to talk about too. But every single time, Sherrie, I just get this kind of wave of like nausea. It's not horrendous. I don't have to go lay down, but I just don't feel great. And then it kind of wears off and I feel better. But it happens with every single dose. Other people talk about when they take their IR, they feel like just fatigued. like an hour after, I just like, oh my goodness, I just need to lay down. I'm just so tired when I take this medicine. I'm not as rigid, I'm not as slow. My tremor might be a little better. So that is such a great indication to switch that patient from IR to Rythari. Because remember, that peak dose effect, when you take your IR and boom, it goes into the brain, it gets processed. Side effects are the biggest because it comes in and then it goes out because of the very short half-life. So people can experience more side effects on IR than they do on Rythari, just simply because it's nice and smoothly released over a period of time. So you don't get that big old spike causing those side effects.
And how about side effects like anxiety or agitation? Because one person said that they tried it and they were experiencing those kind of side effects, and so they discontinued it. Is that something that you've seen, or?
Not typically. I don't usually see more anxiety. That could be, I do warn patients about that. So as Dr. Hauser was saying, there's a third of the beads that are quick acting, another third that are intermediate acting, and a last third are long acting. And so sometimes when you take Rythari, if people are used to that immediate effect, right? They're just like, boom, they're on quicker and the on is higher, the on medicine is higher. And often with off episodes, we see anxiety. It's not uncommon to see anxiety when people are experiencing low levels of dopamine. So sometimes that could mean when you were taking Rythari or you tried it and you felt anxious, that your brain just wasn't getting quite enough levodopa. It probably just needed to be up a little bit higher and you wouldn't be experiencing that kind of a bit of an off. So that would be my biggest guess about that.
Great. All right. So I want to go back because you mentioned it and we just got a question. So let's talk about protein, timing, and also want to add to that, because I just happened to see somewhere that there may be something related to high fiber, maybe not. That was a question, is fiber even an issue? So can you touch on this a little bit, because that impacts both Rythari and immediate release, correct?
Yes, absolutely, absolutely. So typically we tell our patients to take their carbidopa levodopa, whether it's Rythari or it's IR, either 30 minutes before a meal or 2 hours after a meal. That becomes more challenging as you need to take your medicine at, smaller and smaller intervals. Why do we say that? Well, number one, what we talked about before, remember the gastroparesis. If you take your medicine and you right in the middle of a meal, which we do tell you to take the first month so you avoid nausea, but as time goes on, if you take that medicine on a full tummy, guess what? It's just going to sit there and it's not going to go to where it needs to go. Secondly, if you eat a big hamburger or you have eggs in the morning and you take your carbidopa levodopa, there's little transporters whose job it is to grab the carbidopa levodopa and transport it across the intestinal wall. So protein competes with carbidopa levodopa for those transporters. So there's a finite number of transporters. And if you got a bunch of protein there, the transporters are like, okay, I think I'll grab some protein. I think I'll grab some carbidopa levodopa. They don't have a preference, but it can lessen the effectiveness of your carbidopa levodopa if you take it with protein. So sometimes kind of a good solution to that is, number one, I say pick three. We're talking at the beginning, right? So let's just say you're on 3 doses a day, whether it's IR or whether it's Rythari. And I find it's easier just in terms of lifestyle to pick 3 times. Don't judge, okay, wait. They said a half hour before, 2 hours after. Oh, but wait, today I'm going to meet my son-in-law for lunch and I don't think we're meeting till 1. So I've got to remember to take it at 12:30, but tomorrow I'm going to have lunch at 12. Too confusing. It makes your life way too much work. So pick 3 times right when you get out of bed, or sometimes I tell patients, just take it before you get out of bed. Just keep it on your bedside table, drink it with, a nice, cup of water, and get it to where it needs to go down there in that jejunum. The second one around 11. I don't care if you eat at 12, at 11:30, 1 o'clock, a late lunch at 2, it doesn't matter. And then the last dose around 4. And again, it doesn't matter if you eat an early dinner at 5 or if you eat at 6 or even 7. But that way everything, we are all creatures of habit. And so once you've developed 3 times that you're going to take your medicine, it's like ding, you just remember it. First, you have to set of course, your smartphone or your Apple Watch or your little timer in your pocket or whatever it may be, so you remember. But oftentimes that just makes life a lot easier and you tend not to forget your medication. I do want to mention that it is very important not to take your carbidopa, levodopa sporadically. Your brain needs dopamine. Your body needs dopamine. Your gut needs dopamine. So if you feel pretty good and it's 11 o'clock and you're like, I need my dopamine that dose today. I'm just going to wait until I feel my symptoms, then I'll take it. We call that chasing symptoms. We don't want you to do that. Think about what is the kindest thing you can do for your brain. Your brain, remember, is used to bathing in dopamine. So we try to simulate bathing in dopamine, not just for movement, for memory, for mood, for digestion. So really important to set a schedule and stick to that schedule like clockwork. You'll feel better.
Fantastic. And I think talking a little bit about gastroparesis and all that is a perfect segue into the clip regarding Duopa. So we have just a few minutes. So I want to show this last clip and then we can talk through that.
So Duopa has to do with a pump that is connected to a tube that goes through the abdominal wall, through the stomach, down into the small intestine, and delivers carbidopa, levodopa right to the intestine where it gets absorbed. So it's very good at getting the levodopa right where it gets absorbed and getting things very smooth in the blood. And it's really quite effective, but you have to be prepared to carry around the pump, and you have to be prepared to deal with when the tubes get plugged up or the tubes come out, you have to get them fixed. So there's more to do with it, and you just have to be prepared to handle that.
Okay.
Yeah.
Talk a little bit about Duopa because it is a great option for some people. And I'm curious as to, at what point would we want to consider Duopa?
So when do we consider Duopa? So we talk about Duopa when our patients are dosing their carbidopa, levodopa frequently. Probably wouldn't talk about Duopa for that patient that is dosing either IR or Rythari 3 times a day. It's not that difficult to take it those 3 times a day when you get on a schedule. But as we keep talking about, that therapeutic window over time does get smaller. And so that medicine that used to work 1 capsule or 1 tablet 3 times a day, then maybe it's 1 4 times a day, and then every 4 hours, and then maybe it's every 3 hours, then it's every 2.5 hours, in order not to have that off time between your doses. When the doses and the frequency of the doses becomes your life, it becomes how you're living your life by the clock, it's definitely time to talk about Duopa, because it clears all that up. One doesn't really have to worry as much about the protein, though we do say focus a lot of your protein at dinner, and then you can avoid that issue as well. But you do, as Dr. Hauser said, you have to be prepared. There is a pump that either goes in a sling, or it goes in a vest, or it goes in a fanny pack. And it's, it's a good size and it's a bit heavy, but it is convenient in terms of You press start in the morning, you put in a little cartridge. The company mails you these little cartridges, like a month's worth every single month. And then your clinician will program the pump. There's 3 ways to program it. There's 3 variables that we work with. One is a continuous rate. So how fast, how many drips per minute, and that's all based on the total amount of carbidopa, levodopa you were taking when you were before you considered Duopa. Then we have what we call a morning dose, and a morning dose is delivered if you take 200 milligrams of, you take 2 tablets or 2 Rytharis first thing in the morning because you have that early morning off. Then we do a conversion mathematically, and there is a morning dose that is delivered right when you get hooked up, and it kind of gives you this nice extra amount that gets absorbed right away, because remember, it goes right to the jejunum, the area in the small intestine. So you get it kicked in right away. So you've got your morning dose, and then it goes to your continuous dose. And if you're just kind of having one of those, a little bit of a rougher Parkinson's day, or you're about ready to go exercise, not everyone does this, and you just want to give yourself an extra little boost, it has a little button on it called extra dose. And then we can set that variable too. That can be anywhere, the range is infinite, right? It can be from equivalent of 10 milligrams of dopamine to levodopa to 200. I mean, it runs a gamut. I had a patient that just recently got Duopa, and he had horrible dyskinesia. No matter what we tried, the Rythari, the half little tablets of Cinnamon all day long, every half, his dyskinesia persisted. And he started on the Duopa pump, and I'm super pleased to tell you that he's doing so much better, because it's that consistent drip, drip, drip right to where it needs to be absorbed. And remember, dyskinesia is caused from the medicine, the burst of the medicine, and the neurons don't know how to handle it. So they either open the floodgates and all your muscles move, or the floodgates don't open at all and you feel super duper stiff and slow, or freezing of gait, all those type of things. So it definitely has its place. And again, it's a wonderful therapy for the right patient, along with, of course, DBS, which is the incredible technology that we have now, is pretty amazing. Again, for the right candidate.
I'm so glad you brought up dyskinesia, because we actually have had a couple of questions. So I'll try to condense them, because we are running out of time. And gosh, there's just so many good things that we can go down and discuss even further. So this person had wanted to know earlier, are some people more sensitive to the immediate release in terms of getting dyskinesias versus Rythari? Is there a difference? Do you see less dyskinesia?
Yes. So one of the first things that I do when a patient starts getting a little bit wiggly, boom, if they're not already on Rythari, they get on Rythari. Again, remember, because dyskinesia is caused from one thing, and that is the medicine. If you never took Parkinson's meds, you would never get dyskinetic, but you would be in a straitjacket. So that obviously isn't an option. But definitely one of the first things I do is convert them. It's still you're still going to take carbidopa, levodopa only. We're going to do the slow release version of carbidopa, levodopa, and we'll see if that takes care of your dyskinesia. If it doesn't, there's a couple, really one in particular, great medication that's on the market now called GoCovery. And that is a kind of an anti-dyskinesia medication. It also really works well for off episodes throughout the day. So it's FDA indicated for both of those reasons. But step number one is definitely to convert them from IR to the nice, slowly released Rythari.
All right. And just to ask, because we haven't heard much about them. They're older meds, I believe, but someone wanted to know about Comptan. Okay. And I wanted to know about Stalevo. Are these used much anymore? And can you explain those real quick?
Yeah, absolutely. So Comptan is what we call a COMT inhibitor. It basically is added with carbidopa, levodopa. It doesn't have to be. You can actually take Comptan. It comes as one dose. It's a 200 milligram dose. And some patients that are stocked up on tons of Sinemet or even Rythari, but typically it tends to be Sinemet, you can take one Comptan, 200 milligrams, and your dose of carbidopa, levodopa. And what it does is it boosts up the amount of dopamine that your brain is exposed to. So in essence, it makes more, there's more dopamine available in your brain for your brain to use. So Stalevo is still used quite often. I use Stalevo. It's a nice way to convert someone. Again, let's just say, for example, they're on 100 milligrams of IR 4 times a day, and I don't really want to increase their dose. But I know that they need a little more support with their levodopa. I'll just take them off the IR and convert them to a Stalevo. So they'll take the same dose, 100 milligrams of Stalevo equals carbidopa, levodopa, 25, 100 levodopa, and 200 milligrams of Comptan. Now, with that being said, there is a drug that was released, I think earlier this year. It's called Ongentys. It's also a Comptan inhibitor, but instead of just lasting a short period of time and needing to be taken with each dose of carbidopa, levodopa, Ongentys, you only take once a day and you take it at bedtime. And so it has a very, very long half-life and it works the same. It's a Comptan inhibitor. You stay on your Rythari, your IR, and then you just add this Ongentys once a day at bedtime.
All right. I think this is the last question we really have time for, because I know you have to hop off, but this person wanted to know about letting their carbidopa levo tablets dissolve in their mouth. And if not, is there other ways to taking it? And I want to tag onto that. If the little capsule of Rythari is difficult for certain people to swallow, they can open it up and sprinkle the beads on applesauce. So there are other ways. I'm going to throw Parcopa out there just to say, is that still used? And do you have anything to say in regards to other mechanisms of getting them in if they're having trouble swallowing?
Yeah. So there is a product which we haven't even mentioned yet, and it's called Parcopa. It's a disintegrating, it's actually created to just melt in your mouth. And for my patients that are having some problems with swallowing, it's a perfect answer to that, because they can just put it on their tongue, it will dissolve on its own, and it comes as exactly the same dose, 25 over 100. It is just carbidopa, levodopa, but it is disintegrating. Keep in mind that the IR, the Sinemet, you can chew it. I'm not saying it tastes like candy, but my patients tell me that it tastes like chalk. It doesn't taste horrendous like that medicine, like really, just horrible taste. It tastes like chalk and it's easy to chew. You can use that. And the Rythari, indeed, you can open up that capsule. You can sprinkle those little beads onto applesauce just fine, and take it that way too. So there are other answers to those folks that are having some difficulty, say, with swallowing, or just, it's always been difficult for them to swallow a larger pill or a capsule.
Awesome. Well, I know that we're out of time and I really appreciate this. I know we didn't get to all of the questions. This was a really good conversation though, because I really think you kind of help break it down even further, help us understand how these things work, what they are. So thank you for that, and going through the clips with Dr. Hauser from before and talking through those. And for those of you who want to go ahead and save your chat, if you go over to the bottom where you type your message and that little 3 dots, if you click that, and it'll pop up a little box and you'll see save chat. We have given you a couple of links. Some of these are to our medications page, where you can look at the different medications that are FDA approved. They have links directly to the website of that drug company, as well as the assistance programs available. And we have the More You Know video series. And I know Sherrie's featured on some of those. As you can see, she does such a great job explaining these things in understandable terms. 3 to 5, I would say, minutes of each of these videos explains the medication. So check that out. We also have given you the link to Dr. Hauser's original talk. So check that out. And then, of course, this is recorded, so it will be up and available to you to view later if you want to go back and kind of catch what you might have missed, because we did cover a lot of stuff. And, I just want to thank you so much, Sherrie, for being a part of this. I want to thank Neil for being our partners in this program. And all of you who have felt like you've gained some knowledge today, would you please give Sherrie the wave of gratitude and our thanks to her time and her expertise? Thank you so much, Sherrie.
Thank you, guys. It was a privilege. Anytime. I love it. Anything I can ever do to educate, and just education is power. So thank you for so many of you being here. It was incredible what a large group was here, and hopefully I'll see all of you soon. So take good care and go out and exercise, all of you. Exercise, it's the key.
Absolutely.
Right? Okay.
On that note, all of you have a great rest of your afternoon and go get your exercise in. Take care. Bye.
Bye-bye.